Hey everyone, it's Nurse Sarah, and in this video, I'm going to go over maternity nursing questions and answers for NCLEX. So let's get started. This question says, your patient is 24 weeks pregnant and you're measuring the fundal height. Which finding below is a normal measurement for this patient? A, 16 centimeters, B, 28 centimeters, C, 26 centimeters, or D, 12 centimeters. To answer this question, you have to remember that with fundal height, after 20 weeks, the number of weeks that person is pregnant is going to match their fundal height, plus or minus 2 centimeters. So try to commit that to memory. So our patient is 24 weeks, so plus or minus 2 centimeters should be their measurement. So on the low end, the minus centimeters, they should be measuring the lowest 22 centimeters. At the highest, the plus part, they could be measuring 26 centimeters. So 22 to 26 is our measurement. Therefore, since we know that information, this question is relatively easy. The answer is C. This question says you're collecting the 1-minute APGAR on a newborn. You note the heart rate to be 140 beats per minute. The baby's cry is strong and regular. The body is pink with slightly blue hands. There is some flexion of arms and legs. While assessing the newborn, it moves and cries. What is the newborn's APGAR score? Is it A5, B9, C6, or D8? To answer this question, you got to be familiar with the APGAR scoring. So this is a quick assessment tool that a nurse can use whenever a baby is born to let you know how that baby's doing. So it's developed by Virginia APGAR, and her last name is spelled APGAR, and we use it as an acronym to help us go through this checklist of things while we're assessing that newborn after birth. So you're looking at the appearance, hence baby's skin color. You're looking at pulse, what's their heart rate. G is for grimace, their reflex irritability. Then we have their activity, hence their muscle tone. And then R is for respiration, their respiratory effort. Now the APGAR scoring is performed at 1 minute and 5 minutes after birth. And if that score is like 6 or less, it'll be reassessed at 10 minutes. Now each of those little categories I went over, you can score them from 0 to 2. So you add those up and the highest score you can get is a 10. Now it's rare for a baby to have a perfect 10 at 1 minute after birth because a lot of newborns are going to have some cyanosis in their feet and in their hands. So to help us answer this question, we got to go through that acronym and score each part 0 to 2 and then add it up and we have our APGAR score. So first is appearance. How does our baby look? The question tells us that the body is pink with slightly blue hands. So that is that acrocyanosis. We're going to give them a 1 for that. Then pulse, we're told the pulse is 140 beats per minute. We're going to give them a 2 for that, so now we're at 3. Then for grimace, we're looking at the reflex irritability. So we're told that the newborn, while assessing the newborn, it moves and cries. So they're going to get a 2 for that, which puts them at 5. Then activity, we're told that the baby has some flexion of arms and legs. So we'll give them a 1 for that, which puts us at 6. And then the respiratory effort, in the question, it says that the baby's cry is strong and regular. So they get a 2 for that. When you add all of that up, you get an APGAR score of 8. So D is our answer. This question says, early decelerations are noted on the fetal heart monitor. The nurse knows that blank is the cause of this finding. In maternity nursing, there are 3 types of decelerations that you want to be familiar with for exams. We have early, variable, and late. So you want to be familiar with what they look like and what causes them, because this question specifically wants to know the cause of early decelerations. So with early decelerations, we are not concerned about this. We expect this to happen because what's happening is that while the baby's inside of the uterus is contracting to help push the baby out. And as it contracts, it's going to put compression on the baby's head. When it does that, we're going to stimulate the vagus nerve because we're compressing it, and that's going to drop the heart rate. So that's an expected thing to happen. Now with variable decelerations, this is not a good thing. So if you see this, bad sign, because what's happening is that every time mom is having a contraction, it's causing that baby's heart rate to just plummet. And a normal fetal heart rate is anywhere between about 110 to 160. So what usually causes this is that the umbilical cord is being compressed. So we know that that's not an option, so we can go ahead and rule out C for that. But How I like to remember that on whenever you're looking at it is that it looks like a V. So you have mom's contraction, and then from where the heart rate just drops so low, it looks like a V. That's how I remember it. And then with late decelerations, which is also a bad sign, is that what's going to happen is that baby's heart rate is going to plummet long after the beginning of mom's contraction and then recover way after mom's contraction is over. And this is usually caused by uteroplacental insufficiency. So we can go ahead and mark off A. So D is just like a distractor, prolapsed uterus, where you can mark that off as well. So our answer is B. Baby head compression from uterine contractions is what's going to cause those early decelerations. Here we're told during an assessment of a laboring woman, it is noted the fetal station is +2. You interpret this to mean what? So let's talk about fetal station. What is this? Well, this tells us where the baby's presenting part is located in the pelvis. So when we're talking about presenting part, we're usually talking about the head, because most babies are head down and that's how they're going to come out. But sometimes babies like to throw us off, and it could be their hand, their foot, or so forth. So in other words, this fetal station is giving us an idea of how far that baby has descended down in the pelvis so we can be prepared for delivery. So how is fetal station measured? Well, you want to remember an important landmark known as the ischial spine. So this question tried to trick you in its options by throwing in iliac spine. That is not the landmark we use, it's ischial spine. So go ahead and eliminate A and B. So you have a right and a left ischial spine. If we drew an imaginary line, it would look something similar to what this picture is on the screen, where this baby's descended down in the pelvis. And so what we're looking at are 5 centimeters above that line and 5 centimeters below that line. And when we report fetal station, we don't say the baby's at 2 centimeters above the line or 2 centimeters below the line. We refer to it in negative or positive numbers. So here's our line. Everything above the line from up to 5 centimeters are negative numbers, and everything below that in the line are positive numbers. So how I like to remember that is that, okay, if we're in the negative, unfortunately, that means our baby is still in that pelvis. It's not ready to be delivered yet. So on the negative side, mom is still in labor. But if we're in the positive side, okay, things are going, baby's almost here. This is a positive for mom. They get to meet baby and labor is going to be over. So our question tells us that the fetal station is +2. So get your line out and just think, these are negative numbers, these are positive numbers. We're at +2. That means baby's almost here and labor is almost over. That is a positive thing. So based on our options, is it C, the baby's presenting part is 2 centimeters above the ischial spine? Remember, above were those negative numbers, so nope. And then D, which is our answer, the baby's presenting part is 2 centimeters below the line, and that is our answer. This question says your patient is 48 hours postpartum. While assessing fundal height, you would expect the fundal height to be what? So during the postpartum period, we are paying close attention to that fundus of the uterus. We want to make sure that it is firm and midline, it's not soft and boggy, and that uterus is starting to shrink down, where eventually it will go back to pre-pregnancy size. So we're going to be looking at that fundal height. So there is a general rule that you just want to commit to your memory so you can get questions like this right. So during that postpartum period, the fundal height should decrease by 1 centimeter per day below that belly button. So if your patient is 48 hours like they are here, they're 2 days. So according to that rule, they should be at 2 centimeters below the belly button. So our answer is B. Here we're told we have a patient who is 27 weeks pregnant and they have had a 3-hour glucose tolerance test performed. Below are the patient's results. So we need to interpret the results as either normal or abnormal. So again, we have one of those alternate format questions. We have where it's the patient's report of what those results were, and then we need to click the drop-down box and tell if it's normal or abnormal. Typically, a 3-hour oral glucose tolerance test is performed because a patient did not pass their 1-hour oral glucose tolerance test. So they need further investigation because we're trying to rule out gestational diabetes. So for this, what's going to happen is the patient's going to have to come back to the office. They're going to be there for a little while, and before they come, they have to make sure that they've been fasting, and then immediately they're going to get a blood draw. And then after they get a blood draw, they're going to have to drink about 100-gram solution of glucose. And then at the 1 hour mark, they get more blood drawn, then 2 hours, they get more blood drawn, and then 3 hours, they get more blood drawn. So with this, we are looking at how those glucose readings are trending. And what we're looking for with those measurements are 2 or more abnormal results during those hour intervals when we measure the glucose. And that would point us to gestational diabetes. And on your screen, you're going to see what those abnormal results would be during those intervals. So the initial blood draw, or fasting one, where the patient shouldn't have anything in their system, an abnormal result would be that their sugar was greater than 95 milligrams per deciliter. Then they take in that oral solution, and we expect their glucose to go up because they're taking in some. So at 1 hour, we would not want it greater than 180 milligrams per deciliter. Then as the next hour goes, we want the glucose to be trending downward. So an abnormal result at 2 hours would be greater than 155, and then at 3 hours, which should be a lot lower than the first and the second hour, an abnormal result would be greater than 140. So now that we have that information, we just have to plug it into this table with this drop-down box. So with the fasting, the patient's is 94 milligrams per deciliter. So they're sort of on the edge a little bit, but it is less than 95, so we're going to put that it's normal. Then the next one, the 1 hour, was 210. We know that it is going to trend upward because they took in some glucose about an hour ago. However, we don't want it that high, so because anything greater than 180 would be abnormal. So that's abnormal. And then we have 2 hours, it was 180. We want it, that's high, so that is going to be abnormal because anything greater than 155 was abnormal. And then let's see what their 3 hour one was. It was 130. So they're actually normal for that. So we're going to put normal because anything greater than 140 was abnormal. So based on this, they have 2 or more abnormal results. So they definitely are looking at gestational diabetes. This question says a 28-year-old patient gives birth to twins at 38 weeks gestation. This is the patient's first pregnancy. Which option below best describes the patient's gravidity and parity? Is it A, gravida 1, para 1, B, gravida 1, para 2, C, gravida 2, para 2, or D, gravida 1, para 0? To answer this question, we have to review gravidity and parity. So gravidity is the number of times a person has been pregnant, regardless of the outcome. And in this question, we're told this is the patient's first pregnancy and that they just gave birth to twins. So we know they've been pregnant once, but they've had twins. Now, a lot of people get confused on this, but don't let this confuse you. With gravidity, multiples, it doesn't matter if they're having triplets, quadruplets, a million of them, I don't know. It only counts as one pregnancy. So it would be gravida 1. Okay, we have that. Now, let's talk about parity. Parity is the number of births, so hence completed pregnancies after 20 weeks of gestation. So we're told that this pregnancy ended at 38 weeks gestation. So again, just like with gravidity, multiples, hence twins, onward, they count as 1. So don't let yourself think it's 2, but it's 1. So we have a gravida 1, a para 1, so our answer would be A. Here we're told we have a patient with preeclampsia and they're started on magnesium sulfate. The nurse knows to have what medication on standby while the patient is receiving this medication. Preeclampsia is a hypertensive disorder that can occur during pregnancy. It typically happens around 20 weeks gestation. And unfortunately, what it can lead to are seizures. So we don't want a pregnant person to have seizures because it can lead to death and death of the baby. So whenever a patient's receiving magnesium sulfate, what it's going to do is it's going to slow things down and decrease the risk of the person having a seizure. However, whenever they're on magnesium sulfate, we got to make sure we're not giving them too much magnesium sulfate. Signs and symptoms of toxicity with this is that they have decreased deep tendon reflexes. So that's why we're always checking those. And if that happens, we need to give them the antidote. And you just need to remember the antidote for magnesium sulfate, and it is calcium gluconate. So based on this, we know that our answer is D. This question says, during a prenatal visit, a patient tells you her last menstrual period was August 15th, 2016. Based on the Nagel's rule, what is the estimated due date of her baby? Nagel's rule is used to estimate a baby's due date based on the patient's last menstrual period. And its calculation is based on that the patient's going to have a 28-day cycle and that the gestation period is going to last for 280 days, which is 40 weeks. And we know that that's not always the case. A lot of patients don't have 28-day cycles, and a lot of pregnancies go on a little bit longer than 40 weeks, especially for first-time moms. So this is just really an estimation for a due date. So whenever you're calculating this, you want to take into account some things because some months are a little bit trickier than others. First of all, the month of February, some years there's a leap year. So we're not even going to add the leap year with the 29 days because we know February has 28. Just always give February 28 days. Also, know which months have 30 days versus 31 days. So again, September, April, June, and November all have 30 days. So we're told our patient's last menstrual period was August 15th, 2016. So first, what we're going to do is we're going to subtract 3 months from that last menstrual period. When we subtract 3 months from August, we get May. Then second, we are going to add 7 days to that last menstrual period date. It was the 15th, so when we add 7 to that, that gives us 22. And then we're going to add a year. Do not forget to add that year because that would be an easy mistake to do. So we know the patient can't have it in 2016, so add a year, so it's going to be 2017. So our estimated due date is May 22nd, 2017. Now the way that you calculate that, it is best used whenever the patient's last menstrual period falls between the months of April and December. However, if it fell between January to March, just so you don't get confused, it may be a little bit easier to do the following. Add 7 days to the last menstrual period and then just add 9 months. So just keep that in mind whenever you're doing this rule. This question says a 36-year-old patient who is 38 weeks pregnant reports having dark red bleeding. The patient experienced abruptio placentae with her last pregnancy at 29 weeks. What other signs and symptoms are likely to present with abruptio placentae? Select all that apply. Abruptio placentae, also known as placental abruption, is where that placenta detaches from the uterine wall. This could be partial detachment or complete detachment. Whatever it is not good for the baby or the mother because we have learned that the placenta is really what provides the baby with nutrients. So if we're detaching that from the uterine wall, we're going to limit the nutrients and oxygen that baby can get, and instead it's going to keep its waste and deoxygenated blood, which eventually can lead to fetal death. In addition, the mother can hemorrhage and develop DIC, which is disseminated intravascular coagulation. So with this, you want to remember how the patient is going to present. And remember this mnemonic I created called detached. So D is for dark red bleeding. E is for extended fundal height. This is going to be for concealed bleeding. T is for tender uterus, A, abdominal pain / contractions, C, concealed bleeding that can stay inside the uterus and then backflow into the fallopian tubes. The patient can enter shock without even seeing the amount of blood loss. H is for hard abdomen. E for experiences DIC. This is a super event of clotting in the body followed by a depletion of clotting factors that leads to uncontrolled bleeding and possibly death. And then lastly, D for distressed baby, you're going to see heart rate tone abnormalities. So based on that information, all we have to do now is just check our boxes. So decrease in fundal height. No. We know from that mnemonic we're going to have an increase in fundal height because we can have some concealed bleeding, so we're not going to check that. Hard abdomen, yes, check that. Fetal distress, absolutely. They're being deprived of oxygen and nutrients, so check that one. Abnormal fetal position. This is actually going to present with placental previa, where we have a low-lying placenta. Sometimes it can be over the cervix. Because it's not positioned where it's supposed to be, that alters baby's position in the womb. So that would be more with that condition. And then T, tender uterus, absolutely, from where we've had the detachment of it. So we're going to check that. Here we have a 25-year-old patient who is 18 weeks pregnant that reports feeling fluttering in the lower abdomen. The patient states it feels like the baby is moving. This is known as what? In maternity nursing, there's a lot of specialized terms that are used. And anytime you see those terms, you want to make sure you commit those to memory because chances are they're probably going to be on a test. So let's take each of these options and eliminate them. Okay, so the patient is reporting fluttering. It's like the baby's moving. What is a fancy term that they're going to use in maternity nursing for that? So let's look at A, ballottement. What is this? Well, this is a probable sign of pregnancy, and this is where there's the returning of the fetus. Hence, the fetus is just like bouncing up against the examiner's fingers whenever the fingers are pushed onto the uterus. This is like external ballottement. This is not what the patient's reporting, so we can X that out. B, quickening. This is a presumptive sign of pregnancy, and what's happening is that the person is feeling the baby move in the abdomen. A lot of times it's described as fluttering, like here in this question in the lower abdomen, or some people even say it feels like gas. And it can happen as early as 16 weeks. This is usually for second-time moms who've had babies before. So that's looking good for our answer, but let's look at the other ones and just go over it just for your knowledge. So with C, APGAR sign, this is where the lower uterine segment is softening. So this happens anywhere between 6 to 12 weeks of gestation. That's not the case here. And then D, Goodell sign. This is where you have softening of the cervix, and this happens about 6 to 8 weeks gestation, so that's not it. Our answer is B. This question says a patient presents with a possible pregnancy. During an examination, it is noted that the patient has softening of the cervix. I wonder where we've heard about that before. This is known as what probable sign of pregnancy? So many of you may already know the answer to this question because we sort of talked about it already. But it's still a good question to go over because it has some of those specialized terms in it that you want to be familiar with because you may see it on an exam. So we've already talked about Goodell sign and APGAR sign, but what about Chadwick's and Palmer sign? Okay, first Palmer. I like to think of the palm of your hand, and with this, what sign it is that the patient starts to get uterine contractions during a bimanual examination. So think about a hand bimanual examination is causing uterine contraction. It's the palm of the hand. That's how I remember that. And then Chadwick's sign is where we have bluish coloring to the vulva, the cervix, and the vagina due to increased blood flow. And this typically happens around 4 weeks of gestation. And how I remember that is I just remember someone named Chadwick and they're sort of bluish colored. So again, the question wants to know about softening of the cervix. So we know that that's a Goodell sign. Here we're told you're performing a routine assessment on a mother after delivery. The uterus is soft and displaced to the left of the umbilicus. What is your next nursing action? Here we have a scenario where we are doing our fundal checks, and typically, whatever based on your hospital's protocol, but typically after birth, you're going to be checking that fundus every 15 minutes for 1 hour and then 30 minutes for 2 hours and so forth. And so you're looking at how it's presenting. How does it feel hard, soft? Is it boggy? What's its position? So here we're told that it's soft and displaced to the left of the umbilicus, the belly button. So that is an abnormal finding, and whenever you see that, that should be sending off little bells. Uh-oh, that's not good. So as a nurse, I need to do something to help that out. And what have I been taught that I do that will help that out? So what you're going to do is that you want to make sure that you are providing fundal massage. Those are not fun for the patient, and I can tell you firsthand because I've had it done to me twice from having 2 kids. They are not fun, but they're necessary. But anyways, that was a side note. So you want to do fundal massage and have the patient go to the bathroom, because many times why it's presenting like that, soft and displaced is because there is a full bladder. So that's one easy step that can be taken to do that. So that should be the next nursing action. Therefore, A is our answer. So why are the other ones not the answer? Well, B, continue to monitor the mother. This is a normal finding. No, it's not. So that's not the answer. C, notify the healthcare provider. That maybe would be a little bit later on if you've done the fundal massage, they went to the bathroom, you're doing those fundal checks, and it's still soft and displaced, then we would do that. But that's not the next nursing action. And then D, administer PRN dose of Pitocin as ordered by the healthcare provider. No, that's not what we're going to do. So A is the answer. This question says a patient who is 39 weeks pregnant arrives to labor triage. The patient's prenatal history includes gravidity 3, parity 2. What signs and symptoms below indicate the patient is experiencing true labor? Select all that apply. This question is going to have multiple answers, and it's really wanting you to be able to identify true labor versus false labor. So it's really just the process of elimination, and we'll check the boxes of the ones that indicate true labor because there's some defining characteristics. Now, I created a mnemonic to help you remember the signs and symptoms of true versus false, and it's really easy to remember. So for true labor, you're going to remember the word true, and then for false labor, you're going to remember the word fake. So true labor, we're going to have timing of contractions regular, radiating contraction pain, unable to relieve contraction pain with activity, exam changes present. And then for false labor, we have fake. So fails to cause changes to cervix and baby's position. Activity diminishes contraction. Keep feeling contractions above the belly button. They don't radiate from back to abdomen. And then erratic timing of contractions. So now we're just going to take that information from the mnemonic, particularly the true labor mnemonic, which was true. And we're just going to eliminate what we don't need. Okay, first up, the patient states the contractions are located above the umbilicus. That is with false labor, so we can delete that off. Changing positions and walking does not decrease discomfort. That's with true because the U part of our mnemonic was unable to relieve contraction pain with activity. Person's trying to do other activities to make the pain go away and it's not helping, so check that one. The contractions are regular. Yep, that was the T part. Check that. And then the cervix is 90% effaced and dilated to 4 centimeters. So that was the E part, exam changes present. So we're going to go ahead and check that. Okay, so that wraps up this video over maternity nursing questions and answers for the NCLEX exam. And don't forget to access the other videos in this series by clicking the link in the description below.